I'm Jonathan J. I'm a board-certified urologist with Advanced Urology Institute. Listen, I'm excited about all facets of urology. You know, cancer is a big thing. Remember, prostate cancer didn't have a chance when he died of a heart attack at 60 and 70. But if he lived to be 90 and 100, prostate cancer's got a big chance. A big chance. We're going to see a lot of patients actually their lives being affected by this disease. So one of the things that I like is that our ability to define the disease is improving. For instance, not only do we have PSA, stands for prostate-specific antigen. This is a protein excreted by the prostate that can be detected at certain numbers, or just be a certain number within the serum at a certain age. And if it's elevated, or if it's different than it used to be, then we know something's wrong. And that's important to understand. PSA got a bad reputation. Why was that? Because we used it wrong, not because it was a bad test. The significance of PSA is not what it is in you relative to average, but what it is in you over time. For instance, my PSA for the past 10 years has been 1. If my PSA is 3, which is considered normal, something's wrong. Mr. Jones has a PSA of 6 for the past 10 years. This is above average, but he doesn't have prostate cancer because his PSA is stable. So again, we use this PSA in a wrong manner. That's been one of the great evolutions of understanding this. And understanding too, there's some molecular biology. Again, we used to grade prostate cancers by looking at a prostate cancer under a microscope and looking at the pattern and what it looked like. You can't really tell the aggressiveness of a prostate cancer by looking at it in its morphology. For instance, you've got two people walking down the street, you've got a young kid with a hoodie on, you've got a well-dressed man with a trench coat. Who's your bank robber? Well, the guy with the trench coat has a machine gun under his trench coat. You can't tell the behavior of something by the way it looks. So what we've done with prostate cancer is we have the ability to take that cancer, look at the genetics, and define if it can multiply fast, can it move to other places. We can look at the virulence factors of these cancers to tell which cancer should be treated and which cannot. This is early in the process of looking at molecular biology and making a decision on how to treat and who to treat for prostate cancer. But it's the light that we need, and as we hone this in and be better at defining it, we're going to make better decisions on who to treat and not to treat.